Energy and Commerce Subcommittee on Health and Environment is Congressman Henry Waxman.
Help. The result has been an epidemic of measles. In 1978, there were more than 26,000 cases of measles. That year, the federal government began a drive to get children immunized. With these new efforts, measles was driven back to a low of 1,500 cases in 1983. Measles was once thought to be an inevitable childhood disease, but in 4 years it was shown to be 100% preventable. Over the past years of tight budgets, however, the immunization programs have been eroded. When money was limited, it was spent to buy the vaccines, but the workers to find unimmunized children were moved to other jobs or dismissed. Fewer and fewer people were left to reach unvaccinated children. The result has been predictable. After years of work and then years of erosion, there were almost 25,000 cases of measles in 1990, virtually where we began. The problem is clear to see. Vaccination programs are limited. Clinics are inaccessible, appointments are required, and waiting lists have grown. Public awareness is also low. Many parents are waiting until their child is ready for school, even though the biggest danger is to infants. And sadly, some parents are complacent. They mistakenly think that measles is only a rash and a few days in bed, when in fact it's a dangerous disease that can result in deafness, brain damage, and even death. The federal government has the main responsibility for ensuring that immunization programs work. One state's epidemic rate is only as good as the next state's vaccination program. Working with state and local governments, the Centers for Disease Control should meet its stated goal of eradicating measles within the United States. Instead, the CDC has been forced to limit and cut back. In January of this year, the Advisory Committee of the National Vaccine Program issued a report on the measles epidemic. That report outlined the failings of the current system and the steps that must be taken to remedy the problem and eliminate measles. Following directly on the heels of that report's release, the President's budget for fiscal year 1992 proposed an increase in the immunization program of $40 million, the first presidential request for a significant increase in 10 years. Much of that proposal is in response to the measles outbreak. This is good news. After years of neglect, the immunization program can begin to repair its losses and perhaps begin the task of lowering childhood disease. I hope that today's hearing will begin two responses to the problem. First, and most directly, I hope that parents will hear and read of this meeting and have their children immunized. Vaccinations are generally available, even for those with no money. Second, I hope that we can begin to build a record to produce increased federal funding for this very popular but often neglected program. After years of limiting funds, the President has started the initiative. We must examine his request to see if it is sufficient, and we must respond. We're pleased to have a number of witnesses here to testify today on the measles epidemic. Our first witness at today's hearing is Dr. Fernando A. Guerra, Chairman of the Subcommittee on Measles of the National Vaccine Advisory Committee. This committee was established by Congress in 1986 to review and respond to various issues related to vaccine development, supply, and distribution. In response to the nation's measles epidemic, the National Vaccine Advisory Committee has recently released its report, The Measles Epidemic, the Problems, Barriers, and Recommendations. Known as the Measles White Paper, this study includes several recommendations for addressing the current measles outbreak. As chairman of the Advisory Subcommittee on Measles, Dr. Guerra has been invited here today to present the findings of the Measles White Paper, and without objection, I'd ask that the report be included in the record. We've also asked Dr. Guerra to testify because of his own frontline experience in dealing with the measles epidemic. As Director of Health for the San Antonio Metropolitan Health District, Dr. Guerra has been addressing this problem for some time now. Dr. Guerra, I want to thank you very much for coming to our subcommittee, but before calling upon you for your oral presentation. I'd like to acknowledge the presence of a very important member of this subcommittee, Dr. Roy Rowland, and see if he wishes to make any opening statement.
Other than just to commend you, Mr. Chairman, for this hearing. It is certainly unsettling to realize that we have a significant increase in the number of measles cases throughout our country. While measles was at one time thought to be a benign childhood disease, we know that that is not true. It is a very dangerous disease and certainly has some very bad sequelae in children, varying all the way from minor to death. So I certainly commend you for this hearing and appreciate the witnesses being here today.
Thank you very much. Dr. Guerra, your prepared statement will be in the record in full. What we'd like to ask of you is to limit your oral presentation to us to no more than 5 minutes, and we'll have to ask all witnesses to do that so that we can complete the schedule and have opportunities for full questions and answers.
Thank you, Mr. Chairman, and for me it is a privilege to be with you this morning and members of the committee. I am Dr. Fernando Guerra, member of the subcommittee on measles of the National Vaccine Advisory Committee, and also a local health officer for the city of San Antonio and its surrounding county of Bexar. The Committee on Measles that was brought together by the National Vaccine Advisory Committee served the purpose of calling attention to a healthcare system that is in some state of disarray and that is not so user-friendly as it has perhaps contributed in one way or another to an emerging measles epidemic in this country over the last 2 years. I would initially state that the measles outbreak is a sentinel event, again, for a system that has not always been so responsive to the needs of its communities. For my testimony, I would like to excerpt from the measles white paper and to highlight for you the key recommendations of the committee. It is, in the instance of improving the availability of immunizations, that there must first be adequate financial support provided to state and local health departments to enhance the vaccine delivery infrastructure, the opportunities for having available professional staff, community outreach workers, and a system that is responsive. There must also be vigorous efforts, including legislation, if necessary, to ensure that all managed healthcare systems provide immunizations and that all third-party payers should cover routine childhood immunizations as part of their basic benefits package. In the third instance, Medicaid, including the early periodic screening, diagnosis, and treatment program, should assure that all covered children receive vaccines by appropriately and adequately tracking and assessing immunization status, assuring providers are adequately reimbursed for vaccines and the vaccine administration, and making sure that providers receive vaccines purchased through low-cost federal contracts. As you know, the early periodic screening, diagnosis, and treatment program of Medicaid has not been as effective as it should be in our state. As an example, it is presently only serving 27% of those that are eligible. Fourth recommendation is that national and community level efforts should be enhanced to build grassroots support for adequate resources for immunization and to enhance local requests for immunizations. In this instance, the national efforts of the National Association of Junior Leagues and Rotary International are important programs that should be a part of the national vaccine effort. We should also improve the management of the immunization delivery system, with the fifth recommendation being that the National Vaccine Advisory Committee, in collaboration with public and private sector groups, should issue a formal set of minimum program standards for immunization practice across all immunization efforts in this country. These standards should assure that immunization is available on request at times that are convenient and that children are not required to have an associated comprehensive physical examination when they are not so readily available. The sixth recommendation is to improve access to care. The National Vaccine Project, chaired Intergovernmental Coordinating Group on Access to Immunization, should develop and implement a comprehensive plan to assure the clients they serve are adequately immunized. And the seventh recommendation is that immunization status should be assessed routinely for persons enrolled in the WIC program or for women, infants, and children, and aid to families with dependent children. Children in need should either be offered vaccines on-site or referred for appropriate vaccine follow-up with appropriate recommendations and immunizations at that time. The eighth recommendation is that the National Vaccine Project, through the CDC, should collaborate with major healthcare provider organizations to encourage the adoption of policies which diminish barriers and take advantage of all opportunities to vaccinate. Too many children are accessing the healthcare system in a fragmented and somewhat disordered way. We should maximize those opportunities. The ninth recommendation is that state or local governments which have not as yet done so should enact and enforce legislation to mandate appropriate immunization prior to enrollment in licensed daycare centers. In our own experience, when we developed the child care ordinance in our community from one year to the next, we observed a very significant reduction in the vaccine-preventable diseases, with Haemophilus influenza meningitis being decreased from 55 cases in 1989 to 8 cases in 1990. There should be ongoing measurement of children's immunization status, and this is the ongoing assessments that are done, but this should certainly be supported at a level that we must be able to assess on an annual basis at the national, state level, especially in those high-risk urban and rural areas, the immunization status of a community. For other measles prevention needs, the recommendations would be that the 2-dose schedule for measles, mumps, rubella vaccine should be implemented across the country. This has been determined to be most effective. Additional resources should be made available if current funds are found to be inadequate. There should also be established a rotating fund for outbreak control that would allow us to avoid the need for emergency appropriations to control unforeseen vaccine-preventable disease outbreaks. And finally, there should be enhanced laboratory epidemiological and field studies to allow us to more effectively diagnose and respond to emerging outbreaks of measles. And I thank you, sir.
Thank you very much, Dr. Guerra, for your testimony and for the hard work that your subcommittee did to prepare these recommendations. You've recommended a number of areas where we can reach out to people to bring them in to be immunized, to make the parents understand that children should be immunized, to make sure that it's available in places where it would be available, in fact, to many of the people who need it the most. In addition to making these recommendations, you're handling a program in San Antonio, which I understand has been successful. Can you tell us why the program in San Antonio has been successful, since the problems in San Antonio are so close to the problems of other areas of the country where we've lagged behind in getting children immunized for measles?
Well, in response to that, Mr. Waxman, I would say that we have tried through the shared responsibilities in both the public and the private sector and the delivery healthcare system to keep immunization as a concern for the entire community. It is something that is day after day and month after month and year after year, something that we try to keep out in front of the community as a shared responsibility, and one that maintains a state of awareness across all sectors. Granted, we have our own group of, at times, hard-to-reach individuals in our community, and in those instances it does require a fairly intense kind of effort with outreach into the community, trying to, at times, even do door-to-door campaigns in some of the housing projects where we have observed that the immunization rates are quite low. We use the media quite often to put out a variety of messages, try to make them as culturally sensitive and relevant to all sectors of the community. We try to have extended hours of immunization services, including evenings and weekends. And most recently, we have incorporated some of our basic immunization services within our major WIC sites, and having it as an on-site kind of effort. Previously, we were just using the WIC clinic as an opportunity to screen for immunization status, and found that that was not enough, and that even though we might refer to immunization clinics, it is again a matter of access and availability for many of the parents that are trying to keep up with some fairly complex logistics, and by having it on site, that has really enhanced the immunization effort.
I noticed that one of the recommendations of the white paper was that we have these sites for women go in for prenatal care or for nutrition, or if they're on welfare, for their welfare services, that these sites for those other programs be used for immunizations to take place right then and there, not just to assess whether it's been done. The Centers for Disease Control has been thinking about a linkage, not just using those sites, but saying that if people don't get their children immunized, then the parents will lose eligibility for nutrition programs or Medicaid or welfare. What do you think the impact would be if we had that kind of a linkage?
I think that having a linkage where one can facilitate access and where one can use a system that is already in place, and that is screening individuals for a variety of criteria and or eligibility, that one could use it very effectively if one could do the same thing on site. I think under no circumstances should that be as a barrier to, in terms of individuals seeking eligibility for AFDC or food stamps or WIC programs who have children that are not current with their immunizations, that should not allow them to be eligible for the other entitlement programs. I think that they should work together. They can serve as enhancements, and we have found it to be very effective when we have it in one side.
Ironically enough, your Vaccine Advisory Committee, which served as the messenger that there's a problem, in this case measles, but that we need to do more in the vaccine programs, has been singled out for a cut in the administration's budget proposal, even though they called for an increase in the vaccine program itself. It's like shooting the messenger. Have you heard any explanation of why they would want to cut your committee and what the impact would be if the cuts were made?
Well, I think the impact, again, would be, if it's not measles as an important sentinel for a condition that could have been prevented, there will be others. And I think right now, obviously, with the new initiative for the Haemophilus influenza type B vaccine, for using it in the very young infant with a hope of preventing and hopefully eliminating that as a very serious life-threatening condition, I think that those efforts would be severely compromised. I'm not sure I always understand, why there should be a reduction at a time when there have continued to be so many increased demands for basic immunization services. The shifts that are taking place in communities around our country is evidenced in our own community by a shift from the private sector to the public sector for additional doses of vaccine that in 1 year, from 1 year to the next, we increased by about 65,000 doses that we had to pick up in the public sector within the last 2 years. We cannot continue to take any significant reductions.
Thank you very much. Dr. Rowland?
Thank you, Mr. Chairman. No, in most states, I suppose all states, there's a requirement for admission to school, kindergarten, that certain vaccinations be accomplished. Is that true in all states?
It's my understanding that almost all states, without exception, have a requirement prior to school entry, but that, of course, is effective in terms of immunizing children of school age. It is those that are most vulnerable in the very young age groups that we're especially concerned about. It may be that this is an opportunity as well to try to affect some legislation and or even local ordinances, as we have done in our own community, to require immunizations prior to entry into child care and daycare centers.
Well, that, of course, would be my next question, because the MMR is recommended at about 1 year of age,
yes, sir.
Thereabouts.
Plus or minus 15
and the population that seems to be less immunized is from a level that is eligible for the vaccination if they just avail themselves of that opportunity. And I'm not sure I understood your answer to the chairman a moment ago about whether or not you would subscribe to what CDC is proposing. Would you clarify that for me?
Well, the CDC is proposing that every possible effort be made to facilitate access to basic immunization services within the entitlement program, such as WIC or AFDC, and that if we could use that as an opportunity to also screen for immunization status, with then the opportunity for appropriate referral to an immunization program, or if immunization services could be provided on site in WIC clinics or AFDC offices, that then we could really maximize an opportunity. But that under no circumstances, obviously, would that preclude eligibility for the entitlement programs if a parent, for example, prefers not to have a child immunized at that particular time. And there are those parents that, for one reason or another, or in some instances that perceive that a child might have a condition that would preclude receiving an immunization. I think they should certainly be given that option, but one can link them to a system, hopefully.
We have heard recently of some children that have died because of measles.
Yes, sir.
What is your thoughts about what should be done in these instances? Is a resort to the courts a proper procedure, in your opinion, if they're not immunized?
Well, as in any number of other instances where one always has to advocate in the best interest of a child, that if it is necessary in the instance of an outbreak and that there is great risk for a child in a condition like measles that is associated with significant morbidity and in some instances mortality, that one oftentimes might have to petition a court for some relief in terms of protecting a child against something that is imminent. And I think that could be supported.
Are you aware of any instances where vaccination is not made available because of the inability of the family to pay for the vaccination?
Well, there have certainly been any number of anecdotal observations as the committee reviewed experiences around the country where that has been the case, but it has not existed within public sector clinics, even though there may be fees in place in some of the health department clinics as part of it, the administration of the vaccine and the variety of services that are provided, that should not serve as a barrier. And there is always the caveat that individuals are not turned away or denied a vaccine because of inability to pay. In our own experience, when we implemented the fee structure 3 years ago in San Antonio, we have found that has not served as a barrier at all. In fact, there are many families that, even though their resources are very limited, are very willing to pay for that. We cap it at so much per family, at $5 per family for however many doses are given. What these additional funds have allowed us to do is, in the instance of some response to outbreaks, we have at least been able to very quickly purchase additional doses of vaccine when we've had to respond
so
like that.
So inability to pay really has not been a barrier?
Has not served as a barrier in my experience.
So I suppose one of the principal things that needs to be done is to get the public to understand the importance of vaccination. Every strata in society needs to understand the importance of vaccination and what it means to the welfare of their children.
Absolutely, as a shared responsibility across all sectors in the community, and that in the instance where a family is unable to access the private system of care or where managed healthcare systems are not presently funding reimbursement for vaccines, that certainly the public sector, which perhaps needs to be reorganized and improved in terms of access, is available to them.
Thank you very much. Thank you, Mr. Chairman.
Thank you, Dr. Rowland, Dr. Guerra. Thank you very much for your presentation.
Thank you very much.
We've heard from our next witness before, but not since he's taken on his new position as head of the Centers for Disease Control. Dr. William L. Roper has held a number of top health policy jobs in the Reagan and Bush administration. CDC is the agency responsible for administering the federal childhood immunization program and providing assistance to the states in addressing the current measles epidemic. And Dr. Roper is here today to describe CDC's efforts in these areas. Dr. Roper, we're pleased to welcome you to our hearing this morning and to have you with us. Your prepared statement will be in the record in full. We'd like to ask if you would to limit the oral presentation to no more than 5 minutes.
Thank you, sir. I'm delighted to have the opportunity to talk with you today about immunization programs generally and measles in particular, and the report of the advisory committee that you've just heard. I'm accompanied by Dr. Walt Orenstein, Director of CDC's Immunization Program. Immunization represents one of our most cost-effective preventive health measures. The vaccines we have available today are very effective and have been quite successful in reducing the numbers of cases of vaccine-preventable diseases in this country. Despite the recent resurgence in measles, reported measles incidence last year was still only 3% of the peak year 2 decades ago. These impressive statistics are the result of widespread immunization of all children, particularly school-aged children. Since the early 1980s, more than 95% of school-aged children have been protected. They've been vaccinated. Unfortunately, that's not the case in young children. Measles vaccine is currently recommended for children at 12 to 15 months of age, but we have evidence that in some inner-city populations, less than half of children, particularly poor children, are immunized. That's where we're having this outbreak of measles around the country. In 1989, more than 18,000 cases were reported. That's up from 3,000 cases in the early 1980s. Last year, we believe there were as many as 26,000 cases of measles and approaching 100 deaths. We agree with the conclusions of the advisory committee that this resurgence in measles is primarily due to a failure to vaccinate adequate numbers of preschool children at the appropriate age. Our health system itself bears substantial responsibility for this low immunization coverage. Simply put, we're not taking advantage of all opportunities to vaccinate. And as well, parents seeking vaccination may face discouraging obstacles for the receipt of vaccine. For fiscal year 92, I'm pleased to say the President has requested an additional $40 million for the CDC immunization program, an increase of 19% over 91. Of this monies, $35 million will be targeted to increasing age-appropriate immunization of preschool children. $20 million of this amount will go to grant funds to give incentives for increasing immunization levels among preschoolers. We're right now working with our grant recipients so that they can implement activities to be eligible for these incentive payments. To improve vaccine delivery, an additional $6.3 million is requested for technical assistance to work with state and local health departments to improve immunization programs. They would advise, among other things, advise clinics at the local level to help coordinate immunization services with other public assistance programs such as WIC and AFDC. We're committed to improving access to immunization for clients enrolled in public assistance programs. To this end, we are currently conducting 3 demonstration projects in Chicago, Jersey City, and New York City to evaluate different means of providing immunization services to WIC and AFDC recipients, including vaccination on-site or escorted referral for express lane immunization at nearby clinics. In the President's budget, a further $8.7 million has been requested to increase the number of these type of demonstrations and to determine whether additional benefits can be gained from linking continuation of participation in these programs with immunization. In recent studies that we've done, up to 90% of unvaccinated, vaccine-eligible children who have had the disease measles were also enrolled in one or more public assistance programs, particularly WIC and AFDC. Those children would have been vaccinated by the time of school entry because, as you've just heard, school laws require that. We know that the parents do not actually oppose immunization for their children. They eventually would have been immunized when they got to school. But immunization is just not an immediate priority until it's required for school. We believe that linking immunization with continued enrollment in public assistance programs would have the same impact in increasing immunization coverage in preschoolers as school laws have had in the school-aged population. Let me stress that our intent is to help children enrolled in public assistance programs, not to punish them. Every effort must be made to deliver immunizations with minimal inconvenience to the parent and to the child. You ask about our position with respect to the National Vaccine Advisory Committee recommendations. We indeed support them in principle and are working with our colleagues to see that they are implemented. In summary, immunization is one of our most effective and successful public health programs. We want every child in America to be immunized, fully immunized at their appropriate age. But as I've told you, in some inner city areas among poor children, less than 50% are appropriately immunized. And we are anxious to work with you, Mr. Chairman, members of the committee, to come up with ways of seeing that that number goes not to 60% or 65%, but 95%, just as it is in the school-age population. Thank you very much.
Thank you very much, Dr. Roper. Let me begin by congratulating the administration on its proposal. While you and I may differ on some aspects, I I want to start out by thanking you for your efforts, but I can't help but point out how much it took to get the administration to this point. Measles has been rising in the U.S. for years. This is our third hearing of this subcommittee on measles in 3 years. The administration didn't respond. The President's '89 budget proposal for immunizations didn't even keep up with inflation. The 1990 proposal was to cut immunizations, and in 1991 the proposal was also a cut. Overall, the 3-year total of the administration's proposals for immunization for its entire term in office was less than $400 million. The funding from the Congress was over $550 million. In other words, the Congress, looking at the measles outbreaks and listening to the warnings, gave the immunization program more than 40% above what the President requested. And all that time, while Congress was putting more money into immunizations, the administration was criticizing the Congress for spending too much money. Looking back at it, Dr. Roper, were we wrong to pay more for immunizations? If there's a bad epidemic, even after we in the Congress put more money in than what the administration requested, where would we be if the Congress had ignored all the health warnings and went along with the administration's requests? Wouldn't we be worse off if we had taken the administration's advice than we are now?
Sir, we can use all the money we can get to operate this program.
And if we didn't put more money into it as we had in previous years, we'd be worse off. Is that correct?
I prefer to look forward to the future. Thank you for your question.
Well, I thank you for your response, but the fact of the matter is you can't just use all the money you can get, because there's some limit. It wouldn't make sense to just keep pouring money in.
I understand.
There's a certain amount of money that makes sense to try to do the job. This is not the Defense Department. We're not asking you to go out and defend the national security and to engage in military combat if necessary. We're asking you to reach out to a lot of people who seem to be quite intractable and not getting the vaccines for their children. And that means making sure that they can get those vaccines, because they otherwise may not be able to pay for it, and also reaching them to make sure that they have it available to them. And they're not ordinarily good consumers to watch out for their health interests because they're not sophisticated, they're not in the mainstream. Now, that's not a job that's going to take unlimited money, is it?
No, that's why we've put forward these proposals I've just summarized that would give additional incentives to parents for them to do their part in getting their children immunized.
I don't want to seem unresponsive to the fact that now the administration has asked for more. But I think there has to be some accountability when an administration over the years asked for less and less, and now comes in after Congress put in more money and complained throughout to say that we have a problem and we should be doing more. Shows that the administration is catching on, but it seems to me that they should have cut on long ago. And the point is not just the past. We've got other problems coming up. We have warning signs now about rubella, pertussis, and hepatitis. Specifically, last year, we knew that we needed a second round of measles shots for children. The budget had nothing in it. This year, we know that our own panel recommends that we start children hepatitis shots. That's your panel at CDC, but the budget has nothing in it. How can we fix this budget process mentality in the administration to address these childhood diseases? It's not just a problem of uncoordinated clinics. There are real budget issues here involving millions of dollars. And it seems like once we get to the crisis point, the administration will finally understand it. But until their crisis comes about, until they cause a crisis to come about by not paying attention to it earlier, we have these continuing neglect. Why does the administration keep postponing immunizations efforts, and do you see some process that we can hope to hold on to in the administration that's going to make them recognize these problems earlier instead of until there's a crisis?
My general answer to you, sir, is my job is to make sure that the people up the line in the administration understand the conditions with respect to these diseases and put forward requests to you, the Congress, to meet those needs. You may want to get on to hepatitis and other issues, and I'd be glad to talk about that in detail, but there is a $2 million request for hepatitis vaccine in this budget that the President's put forward. But I think the general point is our belief is we need to do something more than what the federal government has done in the past, and that is purchase vaccine. We need to be looking at ways of dramatically changing the way we think about immunizing young children.
Well, I appreciate that, and while I'm critical of the administration, I do want to point out that you're providing some of the best leadership we've seen in years, and you are sending those recommendations up to those higher up in the administration that were making the decisions, and you have been able to get some of your proposals through, unlike others at CDC in the past who've tried in vain. I have some other questions, but I want to yield now to Dr. Rowland, and then we'll come back.
Yes, sir.
Thank you, Mr. Chairman. Dr. Ope, I'm very pleased to see you here,
Thank
and I
you.
hope that you're enjoying being
Greetings
at CDC
from
now.
Yes, sir, I am.
In looking at the reasons for the deficiency in immunization of children, I believe that you stated that it just doesn't seem to be a priority with some parents to carry their children in for vaccination. Is that the principal reason you think that that they're not vaccinated, or are there some other reasons for this?
If I could use a personal example in answering your question, sir, my wife and I are both pediatricians, and we have a 2-year-old little boy. He got his measles shot when he was 15 months and 3 days old. The principal reason we did that was not because we're pediatricians, but rather because he's enrolled in a licensed daycare center in Atlanta, and they require him to be immunized. And as you heard in response to earlier questions, that has done a lot to seeing that these children are immunized, those that are in daycare, at least licensed daycare. My concern is we who presume to operate these programs need to remove every barrier we can, whether it's financial or convenience as to time of availability or transportation or whatever. But at the end of the day, parents have to do their part as well. And for my wife and myself, we understand how the system works and can navigate it pretty well. For an 18-year-old single mother who's got many other things on her mind, immunizing her 15-month-old or 12-month-old may not be the highest priority. I'm not blaming her, I'm not blaming the victim, but I'm just saying we need to do everything we can to see that parents and the system, whether public or private, work together. I've got a longer answer, but I'll stop there.
There seems to be a common thread in that obstacles are present in access to many different kinds of care. I think about prenatal care for women, the obstacles that they have encountered in trying to get the prenatal care, and I suppose those obstacles are somewhat similar.
Sure. In
the vaccination program. So we need to find some way to get around those obstacles. Maybe, and I harp on this so much, maybe less micromanagement at a higher level of government would be more desirable, and more management at a local level would be helpful. I see you shaking your head affirmatively.
Yes, sir. I was a county health officer in Birmingham, Jefferson County, Alabama, and ran one of these programs, and I'd sure agree with you there. If I could respond to you in a more philosophical vein, I think we've had a debate in this country for more than a decade over programs of this sort, where people in one camp said the answer to the problem is more funding, a larger public presence. People in another camp have said the answer is more individual responsibility and people doing what they ought to do for themselves. What I'm saying is it's not an either or. We've got to do the first, and then we've got to turn to parents in this case to do the other.
I think it is a combination that we need to look at in order to resolve the problem. Let me ask you one other question. You have stated that there are some demonstration projects in some urban areas such as Chicago, Jersey City, and New York City. Let me ask you about the incidence of not receiving immunizations in the rural areas, and what kind of attention is being focused there?
Do we have rural numbers? I'm informed, sir, that we don't have numbers as to immunization rates in rural areas. We've not seen outbreaks of measles in rural areas. Perhaps that's due to the clustering of an epidemic, though, rather than children being fully immunized in the rural areas. We need to pursue the same kind of strategy there as we do in urban areas.
Not very long ago, there was an outbreak of measles in North Georgia, and individuals who were of college age, and in fact it got into the university system. These people were in significant numbers from rural areas. So I want to focus attention on the rural areas, that we should not, just because there's not concentrations of population there, not give attention to those areas. So I just call that.
Fully agree with you. Yes, sir.
Thank you. Thank you, Dr. Roper. Thank you, Mr. Chairman.
Thank you, Dr. Rowland. Dr. Roper, I want to ask you about the National Vaccine Program. It was established to analyze the current status of vaccine development and delivery, and it has begun to do so. You've said that the measles white paper was a useful document, and yet the administration has proposed to cut the program by 76%. From the outside, it looks like some people at OMB who never helped with measles before have now shot the messenger who have warned us about the problem. What do you think the effect will be of cutting this program, especially just after it has produced the document warning about the measles outbreak?
I would urge you to discuss that with Dr. Bart, who follows me and directs the National Vaccine Program. But let me respond. I don't think anybody's trying to shoot the messenger. To the extent that there's any shift in money, I think it's being put into program operations as opposed to centralized activities. But we need to do both. We surely do.
Well, from your own experience, would you say that the program has been of use to CDC?
The National Vaccine Program, yes, sir.
We've heard from state and local health agencies, and we'll have more testimony in a moment, that they don't have enough resources to provide both doses of measles vaccine as CDC now recommends. How much additional funding would be needed to implement fully in the public sector alone the 2-dose schedule?
$10 million, sir.
$10 million. I've read that the immunization advisors are recommending the universal immunization of infants against hepatitis. How much would it cost to implement this proposal?
The Advisory Committee on Immunization Practice, which is a HHS Advisory Committee, just met and came forward with a preliminary recommendation to universally immunize young children. They'll finalize that in June, and we're looking forward to that. We're currently working on the numbers of what it would take to implement that recommendation. Our belief is it couldn't be done in a single year, but ought to be phased over 3 to 5 years. First year cost we would estimate to be about $15 million. It would go up from that to maybe 50 or 60 million when fully implemented.
Over the years, the CDC has consistently said that we need a minimum of a 6-month supply of all childhood vaccines. This stockpile is supposed to be our insurance in case of sudden increased need or interruption of supply from manufacturers. The administration's budget includes no money for a stockpile of vaccines. Do we have a 6-month supply of all childhood vaccines in the stockpile?
Yes, sir. And that's the reason additional funding is not sought for the stockpile.
Okay. We'll hear from Dr. Bart in a moment about the National Vaccine Program. But let me ask you a few questions relating to the vaccine development. As you know, the National Vaccine Program's budget is cut by more than 75% in the President's budget. The budget documents say that many of the program's activities will be undertaken by other PHS agencies. Is CDC going to undertake new vaccine development, and will you be starting new programs to develop or evaluate new vaccines?
We are working with the NVP, but also our colleagues at the FDA and NIH to do that. Yes, sir. Our part of the new vaccine development activity is primarily focused on epidemiology and characterizing populations and the needs of those populations, and then working to undertake vaccine trials once a vaccine breakthrough has been achieved in the laboratory. It's a collaborative effort. We are not doing it on our own.
Would you supply for the record a description of the CDC activities and funding for them in developing and monitoring childhood vaccines such as measles, polio, meningitis, or in other infectious diseases?
Yes, sir. I should mention, you asked about polio. We're the principal agency involved for the United States in the global eradication of polio, an effort we're really proud of and anxious to press ahead on.
It would seem to me that one of the most productive vaccine developments that CDC can do would be to combine vaccines into one shot or dose. If we have trouble getting children in for one measles shot, it must be twice as hard to get them in for two, and even worse for 5 of DPT. Are you working on developing combined vaccines?
Yes, sir. There's a number of folks at CDC, but around the world, that are interested in this idea, and it has the attraction that you just described. Whether or not we achieve that aim of a single shot for a child, it's a worthy goal to hold out there to cause us to stretch ourselves.
There also would be seem to be some questions that CDC could answer about the new meningitis vaccines. I know that the Center for Infectious Diseases has particular expertise in monitoring vaccines and in doing the follow-up epidemiology. Is CDC studying the new meningitis vaccines to compare them and their relative effectiveness?
Did you mean Haemophilus B vaccine, sir? Yes, we are. We have had a number of studies underway, and we'll submit a written...
Submit to the record. We'd like
sir.
to have that. I also understand that there are some new opportunities to develop vaccines against sexually transmitted diseases such as gonorrhea, syphilis, and chlamydia. Is CDC undertaking vaccine research in these areas, and would you submit a description of these efforts?
Yes, sir, and I will.
Just one other question, Mr. Chairman. I want to ask about pertussis vaccine and the dangers associated with that. Can you give me your latest assessment?
Yes, sir. There's a number of folks studying that issue carefully. My assessment is pertussis vaccine is good for children, very good for children, and ought to be widely used. Be glad to give you a further elongated answer, but that's our position.
Well, I knew that there had not been any attempt to discourage the use of pertussis vaccine, but I was just wondering about the incidence of complications associated with it.
There's been a detail
as compared with other vaccines.
Yes, sir. The most questions about any vaccine have been raised about the pertussis vaccine. There's been a great deal of scientific effort over the last couple of years directed at the question you pose, that is, are there harmful side effects to the pertussis vaccine? And the jury's still out on that, but if there is a harm, it's a very small risk, greatly outweighed by the benefits conferred by pertussis immunization.
Can you make any comment about the liability associated with that insofar as malpractice is concerned?
Well, as the committee knows, because y'all were legislating in this area a couple of years ago, it's a very controversial and litigious area, one that I hope that we are working our way through. But it's the vaccine, and all of these vaccines are good for children, and we ought to see that that any barriers, be they access or financial or legal, are removed so that children can be immunized.
I think that's true, and I certainly agree with that. Thank you, Dr. Roper.
Could I, Mr. Chairman, do one other thing if y'all are about to go ahead? This issue of linkage to other public programs is one that you and I have had a chance to discuss, and I appreciate your interest in the matter. I would, if I could, just read 2 short quotes from a recent publication. Another idea came up at a recent meeting of health officials. It would link welfare benefits to vaccinations by making parents show that their children are fully immunized in order to get welfare and Medicaid. If, as a part of the strategy, the government made vaccinations easily and freely available to the poor and educated them about the need, then this might be an effective mechanism. That's exactly what I'm trying to say. That was Carl Rowan in a column that was in the Washington Post about 2 months ago.
Well, I thank you for that quote from Carl Rowland. The fact of the matter is that we haven't made these vaccines as readily available in all these sites.
And we need to do that.
I think our job is to do that, as I'm sure you agree.
Yes, sir.
Before we talk about punitive actions. In fact, if we're going to take punitive actions, we ought to take it against those people who didn't provide the funds so that we could have the vaccines readily available, not the parents who just couldn't find the place to get their kids immunized or didn't have the sophistication to know about it because they weren't educated by those who did know and should have been bringing the case to them. So I'm sorry to disagree with you and Carl Rowan, but I don't think we ought to have that linkage yet. Thank you for your testimony.
Thank you.
Our third witness is Dr. Ken Bart, who serves as both Deputy Director of the National Vaccine Program and Director of the National Vaccine Program Office. The National Vaccine Program was also established in 1986 to direct a coordinated effort among various federal agencies for the development and production of vaccines, as well as the promotion of immunization. Since its inception, the National Vaccine Program has taken on a number of problems related to these issues, including the current measles epidemic. Dr. Bart, thank you for appearing before us today. Your prepared statement will be made part of the record in full. What we'd like to ask, if you would, is to limit your oral presentation to no more than 5 minutes. But we'll take a short break.
Mr. Chairman, in the space available between the tape changes.
Why don't you wait? Dr. Bart, recognize you at this time.
I'm reluctant to take tape time to say that it's going to be difficult putting 8 ounces into a 6-ounce glass. I expected a full 10 minutes, but I'll do my best and respect the time frame that you've asked for. Mr. Chairman, Dr. Rowland, I'm Kenneth Bart. I'm the Director of the National Vaccine Program, and I'm pleased to be here before you today to describe the efforts of the Public Health Service and the National Vaccine Program to improve the nation's health through immunization.
Excuse me, Dr. Bart, I just want to make note of the fact that all witnesses have been told that 5 minutes was the limit. Your prepared statement, though, even though it may be longer to read to us, will be in the record. So we'll have it all in there, and we'll be able to share it with our colleagues.
You're kind to remind me. Thank you. I believe that we as a nation are at a crossroads. On the one hand, there's cause for optimism based on the potential of the new biology and the emerging biotechnology enabling us to improve existing vaccines and develop new ones. On the other hand, there is reason for very substantial concern since our primary health care system is unable to reach all of the nation's children. I believe also that this year is a watershed. The recent report of the measles epidemic and its causes released by the National Vaccine Advisory Committee, which you've heard testimony about, has focused on the problems we face and the need for repair of the immunization delivery system. The prevention initiative in the President's budget for FY92 provides funds to begin addressing this problem. Dr. Roper has described the dimensions of the outbreak and has indicated that now this nation has had in 1989 and 1990 the most deaths due to measles since 1966, tragically. As you know, the 1992 President's budget has recognized the need to improve our record on vaccines and immunization and has consequently requested fully some $495 million in total throughout the Public Health Service for vaccine-related activities. This is an increase of $58 million, or some 13% over 1991. This includes the CDC increase of $35 million referred to by Dr. Roper. Specifically, these funds will be directed at improving the immunization rates of lower-income 2-year-olds, working with states, removing existing barriers, and improving outreach and coordination of services. This will help to ensure that needy children have access to immunizations. I'd like to turn briefly to the National Vaccine Program. This committee, in creating the National Vaccine Program, recognized that maintaining and extending the control of infectious diseases through immunization is an important national objective. Coordination is the word used in your statute to describe the role of the National Vaccine Program. Indeed, immunization can benefit a great deal from coordination because coordination means not missing a single opportunity to protect every child. With proper coordination, no agency will forget it can contribute to universal immunization, no resource that can be brought to bear will be neglected, and cooperation and synergy will be fostered. Now, as perhaps never before, we need to be the best we can be. The Public Health Service has taken the lead through the coordinating efforts of the National Vaccine Program Office and the collaborative efforts of CDC, NIH, FDA, the Agency for International Development, and the Department of Defense to assure vaccine availability and use and to identify and resolve vaccine supply and delivery system problems. The Measles Report was the joint effort of these collaborative agencies and the National Vaccine Program and the National Vaccine Advisory Committee. This is to be one of a series of papers this advisory committee is working on. The committee is comprised of national, state, and local health officers, health practitioners, university physicians, and consumers who advise the Public Health Service on vaccine issues. Simply stated, in response to everything you've heard about the National Vaccine Advisory Committee's report, they told us that the principal cause of the epidemic is failure to deliver vaccine to vulnerable preschool children on schedule. We agree. The underlying issue is the need to improve access to immunization services. The Department is committed to dealing with these problems head-on. I already mentioned the Prevention Initiative in the President's fiscal year 92 budget proposal. In addition, the National Vaccine Program Office, together with the Public Health Service, CDC, and HRSA, is working with the Healthcare Financing Agency, the Family Services Administration, the Department of Agriculture's WIC program, the Department of Housing and Urban Development, and the American Academy of Pediatrics, and others to develop a plan based on the recommendations of this white paper. Many of the problems identified by the report require no resources and are already being implemented. Others will require substantial further study. The National Vaccine Program is also developing a comprehensive national vaccine plan required by the authorizing legislation to provide direction and coordination to public agencies, the private sector, and industry. The plan seeks to assure that everyone who should be protected by vaccination receives all recommended vaccines, that the needed research expertise is directed towards improving existing vaccines, developing new vaccines to extend protection even further, and to foster and support global immunization efforts. The plan is being prepared in consultation with the National Vaccine Advisory Committee, the private sector, industry, and consumers. In its initial years, the National Vaccine Program Office resources principally provided additional support to the development of an acellular pertussis vaccine. The concerted, coordinated efforts of the National Vaccine Program Office and the Public Health Service agencies has brought some 13 new acellular vaccine candidates to clinical testing at the vaccine testing and evaluation units at the National Institute of Allergy and Infectious Disease. This year is the first time support for the NVPO was extended to work on measles and the Children's Vaccine Initiative.
The rest of that statement will be in the record. Thank you very much, Dr. Barr. Let me first of all congratulate you on the white paper on measles. I think it's made a real contribution. Can you briefly tell us what the National Vaccine Program is doing to follow up on that report? What work plans you have?
I described part of that effort in the first few moments, Mr. Chairman. The excitement of the administration on the report is based on the fact that it's provided a focus on problems that have been recognized over the long haul. The specific efforts are based on a coordinated effort to work with the several agencies that are not part of the Public Health Service as well as those within the Public Health Service, coordinating the Public Health Service efforts better, working with the WIC program in a way that they have not been worked with before to look for coterminous and co-facilitation, if you will, of the delivery of services, and with an enthusiasm, received with an enthusiasm that I think is unprecedented. I think we're very optimistic that, in fact, there's a great deal that can be done immediately and has already been undertaken, and we've been so directed to do that.
Thank you. As you know, one of the committee's biggest interests in vaccine has been the development of a safer, effective pertussis vaccine. It's been clear from the beginning of the national vaccine program that this was one of the mandates to you. I know that a significant portion of your office's budget goes to this effort. In fact, last year the President's budget asked for almost a 20% increase to allow you to deal with this. But for 1992, the budget calls for a program cut of 75%. Have the pertussis efforts and trials been discontinued?
Those efforts have not been discontinued. They've in fact been intensified. The apparent budget decrease, which you're referring to, sir, primarily reflects a shift of these resources to the budget requests of the individual agencies for actually conducting this research. And we expect fully that there'll be a concentration on the same areas that were priority in '91.
Well, I assume that the efforts in the pertussis area haven't gotten any cheaper, and in past years you've supplemented these efforts with the national vaccine program funds. Hasn't that been the case?
Yes, sir.
So we will then, what, look to NIH to pay?
It is anticipated that shift of resources will be within the individual agency budgets.
I see. And you will not have a budget that will allow you to participate in helping in that area, is that
That's correct.
Okay. Would you supply for the record a history of the pertussis development funding and a projected costs in the future? The budget justifications of the administration suggest that development activities previously funded by the National Vaccine Program are now built into the budget of these other agencies. Let me first ask that you or Dr. Mason supply a record of the program's expenditures for fiscal year 1990 and 1991, and then show us where these same funds appear in the fiscal year 1992 budget. And then let me ask about that proposal. It's always been my understanding that the National Vaccine Program used its grant funds to supplement other budgets, giving you the bureaucratic ability to back up your coordination plans with NIH or FDA or the Defense Department. Will you have any funds left to do that this year?
The administration budget projected for FY92 does not have those supplemental funds. It's anticipated that the emphasis and the resources for those programs will come from the agencies.
I understand that the President promised the UN that the Secretary, that UNICEF would get a significant effort to develop a children's vaccine initiative, much of which can be used in the U.S., especially in the inner cities that are, for all practical purposes, third world clinic settings. Who has the responsibilities for such activities in HHS?
The Congress appropriated some $5 million in fiscal '91, which was directed towards the development of the Children's Vaccine Initiative. That description you provided us a moment ago was the content of Mr. Bush's presidential address at the World Summit for Children, which occurred last fall. He directed both the Department and the Agency for International Development to invest additional resources in the Children's Vaccine Initiative. The National Vaccine Program, along with the National Institutes of Allergy and Infectious Disease, have the responsibility to implement the Children's Vaccine Initiative using the resources that were set aside, the some $5 million that were made available in FY91.
The $5 million will be made available to UNICEF. Is that correct? From
whom?
No,
it's gone directly to the National Institutes of Allergy and Infectious Disease.
So it'll go to NIH?
That's correct.
And you won't have any grant funds for that?
No, we will not. But that has been a coordinated effort in the planning for the use of those resources.
The National Vaccine Program's first charge was to develop a national vaccine plan establishing goals for research, development, and distribution of vaccines. It seems to me that such a plan would have been a great help in facing a measles epidemic, upswings in rubella and pertussis, and even in dealing with hepatitis. The plan was due on January 1, 1987. When last we asked, it was not done yet. When can we expect the national vaccine plan?
There's been very substantial progress related to the development of the plan. It can only succeed, sir, if it truly is a national plan, not a public sector plan or a department plan. It must be a concerted effort of our constituents, industry, consumers, and the private sector as well as the public sector. The National Vaccine Advisory Committee has committed itself over the last year to the development of recommendations through 7 subcommittees. Those are being incorporated into a draft. The public sector has begun its process of developing its goals. Consultation with the private sector and industry we anticipate will occur this summer and early fall, and we hope that we can, by the end of the calendar year, present such a plan to you.
Would you supply for the record, please, the 1991 and 1992 budget requests for your program that your program made to the Public Health Service, that PHS made to HHS, and that HHS made to OMB? It would be helpful if you would also attach the discussions of what funds were to be used for. Dr. Rowland?
Thank you, Mr. Chairman. Part of your responsibility, as was just mentioned by the chairman, is distribution of vaccine, and developing some program to implement that distribution. You also mentioned that it was not just the responsibility of the public sector, but also the private sector, and many other different groups need to get involved in doing that. I recall several years back in my own community a push to get everyone vaccinated for polio, the saving vaccine, and there was a lot of activity in the local community, and then everyone came to a central point and received the vaccine. Let me ask you this, since one of the big problems is access, as you mentioned earlier, what about the possibility, and I'm sure you looked at this, of mobile units going into neighborhoods, that being widely advertised ahead of time? Dr. Roper mentioned earlier it's really not a priority for many people, and that's the reason the vaccination doesn't take place. And in fact, he used an instance of his own child who was in a daycare center, and they got the vaccination not because they were pediatricians, but because of the fact that the daycare center required that. So looking at it from getting or improving access, doing it on a local level, getting local people involved in it, mobile units where necessary, just an idea that came to mind. If you thought, I'm sure you must have thought about that type of activity, and tell me where you may be with reference to that.
I think the question really reflects nearly 25 years of thinking about how to deliver vaccines in this country. Many efforts have been unsuccessful. We've looked at a variety of models throughout the world as well as throughout this hemisphere. There's been a substantial amount of success using a technique which we believe may not be successful in this country, called mass immunization, which has been successful throughout this hemisphere. Access is a complex issue. It depends on a combination of awareness and demand for service. And I think if, to generalize on your comments, sir, that my feeling is that the demand for immunization is very low. We don't understand the cues on which people respond. We don't know why they come or don't come. And I think the efforts over the last several years that the CDC has placed substantial emphasis on, which funding has been provided for, is embodied in the Infant Immunization Initiative. And that is both to understand better what it is that makes up successful service, but also why we fail. To look at demonstrations of those successes and to begin to explore what it means to deliver services successfully. I don't think we fully yet understand what it's going to take, and I think the kind of outreach you're talking about is clearly what is necessary. Outreach, making clinics convenient, making them accessible, making people bang down the door of this committee's meeting room to demand immunization. There wasn't a crowd of consumers out there demanding immunization, nor are there crowds only because they cannot get clinic appointments. The reason there are crowds are because the service is limited. But the issues of those who are yet unreached remain to be delineated. I don't think we fully understand why we are unable to reach that population.
I guess it's a matter of educating those people, to getting them to understand. The problem is that people don't really care about our health care system until they get sick, and then they're very concerned about whether or not we have a good healthcare system. I guess it has to do with public relations to a large extent. The relationship of the public to understanding exactly what needs to be done in order to deal with a potential problem.
I would suggest that an additional dimension to that is we haven't learned as a public sector to market ourselves very well. We don't present ourselves in a way that makes it either attractive or efficient to be immunized. That may also be true of many other parts of our primary health care system, but simply the marketing of what we have to sell needs to be substantially improved.
Maybe that's the reason that we need to get more involved on a very personal level with people, such as through churches and community groups of various kinds. I think to do that is going to be very important, just as it is in prenatal care, to focus on those types of areas. Thank you, Mr. Chairman.
Thank you, Dr. Rowland. Dr. Barth, thank you very much for your presentation to us. Appearing on our next panel of witnesses are two hands-on health officers, public health officials, who are responsible for administering state programs designed to prevent major outbreaks of disease and to control them when they do occur. Dr. Frances Dunstan is the Commissioner of Health for the state of New Jersey. She is testifying today on behalf of the Association of State and Territorial Health Officers. We'll also be hearing from Dr. James F. Quilty, Jr. Dr. Quilty is Chief of the Division of Maternal and Child Health of the Ohio Department of Health. He is also the immediate past president of the Association of Maternal and Child Health Programs and is representing that organization here today. I want to welcome both of you to our hearing this morning. Your prepared statements will be in the record in full. We'd like to ask each of you to limit your oral presentation to no more than 5 minutes. And Dr. Dunstan, why don't we start with you?
Chairman Waxman, members of the committee, thank you for this opportunity to discuss measles vaccination and the effect of the availability and accessibility of measles vaccine on our population. I am Dr. Frances Dunstan, Commissioner of Health in the state of New Jersey. I'm also a board certified pediatrician and have served as a local health officer for several years. I am here representing the Association of State and Territorial Health Officers and the National Vaccine Advisory Committee. In the past 2 years, a measles epidemic has taken its toll on our children in this country, some 18,000 cases in 1989 and 40 deaths, and 25,000 cases in 1990 and 60 deaths reported. A resurgence of measles has occurred in the United States, and it is a symptom that all is not right within our health care system. At the same time as the nation was experiencing this epidemic, the state of New Jersey was also in the midst of an epidemic which continues into 1991. In the first 2 months of this year, more than 380 cases of measles have been reported. And if this rate continues, it appears that measles cases in New Jersey in 1991 will far outnumber cases in previous years. The epidemiology of measles cases in the years of 1989 and 90 revealed that the increase of measles incidence occurred among preschool children in inner cities. In May of 1990, the Centers for Disease Control conducted a retrospective school-based record review in 8 cities, including Jersey City, Pittsburgh, Cleveland, Seattle, Boston, Houston, Philadelphia, and the Bronx. And overall, in inner city schools, this investigation documented that the percentage of children vaccinated by the second birthday ranged from a low of 51% in Jersey City to 79% in Pittsburgh. And if you look at race-specific data, you see that the vaccine coverage is particularly low among African American and Hispanic children who live in inner cities, and these children will continue to be at risk for measles unless somehow we manage to improve vaccine coverage. In January of 1991, the National Vaccine Advisory Committee adopted a white paper, The Measles Epidemic, The Problems, Barriers, and Recommendations. This report calls attention to the failure of this nation's health system and its inadequate capacity to deliver vaccines to children. The principal cause for the failure to deliver vaccines to vulnerable children is what is causing this problem today. Consistent with the recommendations of the NIVAC white paper, the CDC funded a demonstration project in New Jersey which will evaluate immunizing AFDC-eligible children for measles. Jersey City was the site that was selected, and what we will be doing is the mothers present for AFDC benefits. They will be questioned regarding the children's immunization status, and children's deficient in their children deficient in their immunizations will be immunized at the site immediately and then also enrolled in a comprehensive child health care program. I vigorously support the concept of linkages between federal and state programs and immunizations. However, I have grave concerns about the proposal that would make the eligibility for these programs dependent upon the child being immunized. Great caution must be taken not to exclude a needy family or child of the benefits of a program such as WIC or AFDC because a child has not been immunized. I also strongly support some of the other recommendations in the National Vaccine Advisory Committee's white paper, such as the focus on rebuilding our public health infrastructure so that we can deliver immunizations to preschool children, the focus on the reimbursement policies of Medicaid and some of our other third-party payers that make immunizations basically financially inaccessible. Also, we need to focus on our delivery sites so that they're not institutionally friendly but user-friendly, that they're in proximity to the families that need them, that they are competently staffed, that they're offered at convenient times, and that they're immediately available without waiting lists, and that the services are offered in a culturally and ethnically sensitive manner. Such is not the condition of our current immunization system. And finally, resources need to be directed toward improving the community's ability to communicate the need for immunizations to those who need them. And again, the health education and the marketing efforts need to be tailored so that they actually reach these people. If you look at the President's budget for fiscal year 92, there are several initiatives there that relate to immunizations, and they are consistent with some of the points that I have made in this testimony. However, there are no funds requested for the vaccine stockpile, and I think that this is a significant deficiency. In the view of the emergency needs for measles vaccines in New Jersey with the epidemic that we're experiencing at the moment, I'm very uncomfortable with this omission. And I think it's very important to have that money available in the fiscal year budget for 1992, as well as monies for a 2-dose of measles. Thank you very much.
Thank you very much, Dr. Dunstan. Dr. Quilty.
On behalf of the Association for Maternal and Child Health Programs, thank you, Mr. Waxman, for inviting us to provide testimony about measles. I will use the results of Ohio's immunization program, which uses many of the mentioned recommendations from the National Vaccine Advisory Committee to illustrate the importance of the nation's continued vigilance against measles outbreaks. Ohio has been fortunate in avoiding outbreaks of measles in preschoolers in our inner cities, even though Ohio had a substantial outbreak in colleges and high schools in 1989. Overall, cases decreased greatly in 1990 to 548, and again, no measles outbreaks occurred in our inner cities. Only 22% of measles cases in Ohio occurred among our preschoolers, compared to 47% nationally. These preschool cases were among white children living in rural areas, unimmunized because of their parents' religious beliefs. No deaths occurred. Cleveland was recently surveyed by the CDC as a large city that had experienced no outbreak of measles among the preschool population. The reason? Cleveland had a 79% measles immunization rate for children 2 years of age, a figure almost identical with a retrospective survey we just recently conducted. The immunization program itself has evaluated reasons a preschool measles problem has been avoided. Among the reasons cited are the relationship between the immunization program and the MCH Title V program, a positive relationship with the Department of Education to strengthen the state immunization laws, and the governors and legislatures' continued commitment of resources into immunizations even in tight budget years. Specifically, 3 factors have helped Ohio avoid preschool measles outbreaks. 1, making vaccine available where the kids are. The immunization program evaluates each local area and plans for a wide distribution of the vaccine. The programs continually evaluate and target the distribution of the vaccine to the population in need. Our vaccines go to local health departments, to numerous hospitals, to community clinics that serve inner-city populations. Of course, these clinics cannot charge for these free vaccines. In Cleveland, for example, the public health clinics, while extremely important, serve only a minority of the children in need. Most are immunized in community clinics where they receive their routine care. This makes the families more likely to return for future immunizations. The immunization programs further works with these clinics to make the immunization materials available without an appointment. Means testing is avoided because every child should have access to vaccines. Hiring a person to apply a means test would utilize funds we believe are better dedicated to such activities as outreach. Number 2, expanded use of the federal vaccine contract. The Department of Health and the Department of Human Services arranged a contract recently to purchase all Medicaid vaccines through our federal vaccine contract. Over the past 3 years, $3.3 million has been saved by this contract. Further, the contract has provided an opportunity to identify that segment of the medical community which provides services to this group of youngsters. Further expanding the number of these physician providers is a top priority this coming year. 3, stationing outreach workers locally. As an example, the Ohio Department of Health has stationed 2 personnel in Cleveland for the past 15 years, the lead person being there the entire time. He is particularly dedicated to the immunization program. This consistency of program administration is essential for long-term improvement in assuring high immunization rates. It requires the financial commitment from both state and local health departments supported by a receptive local community. However, the state program remains imperfect. Outreach personnel, especially for hard-to-reach areas, must be added. In addition, the immunization and MCH programs have formulated plans to coordinate more closely the immunization and WIC activities during the next year. In closing, I have used Ohio as an example of how to prevent measles outbreaks. I have addressed the close relationship between the state's immunization and MCH programs. The partnerships established with Medicaid and the Department of Education have been made equally obvious. Ohio wishes to particularly thank our CDC colleagues for their help in this partnership, and Dr. Bart's assistance to Dr. Tom Halpin in Ohio is also noted with much thanks. To curb the recent increase in measles outbreaks and to maintain the vigilance against all preventable infectious diseases, state MCH directors are committed to working with you, our Congress, and our state General Assemblies. Thank you very much, Mr. Waxman.
Thank you, Dr. Quilty. Dr. Dunstan, you said that last year you had 467 measles cases in New Jersey, and that this year, in the first 2 months alone, you've already had 380. Do you have enough funds to buy vaccine, provide immunizations, and search out unimmunized children?
We have sufficient funds to purchase the vaccines. They are made available through our federal contract. But we don't have adequate resources to actually see that they are provided. We have used some of our MCH Title V dollars just recently to extend the hours of clinic services and to provide for public health nurses, so important in those clinic settings. And also, we do not have sufficient funds to do the appropriate outreach. In fact, we need to know more about the type of outreach that is needed. I spoke about marketing and health education in my remarks. We don't have sufficient funds for that.
Dr. Quilty, you've been successful in getting welfare and health agencies to work together to immunize children. You did so with no legal requirements that might cut off people from eligibility. How did you do so, and what can other states learn from your experience?
Mr. Chairman, actually many of the actions that you have taken here in Congress and then that our Ohio General Assembly took allowed us to do some of these actions. In OBR 89 and 90, you required a greater relationship between Title V and Title 19. We had been, for almost a decade from my entry into the Title V program, been involved in expanding those relationships. We have held statewide meetings in which local health departments met with local human service people for the first time. We've had folks such as Sarah Brown and Ray Grad come and speak to those groups. And we have, from the top, if you will, and from the trenches, worked so that when those in the middle administration, such as myself, say we have to get together, that we haven't had to push a great deal. I would say that the questions are still out there about the resources management, but even there we have struck philosophic agreements with the other agencies so that we are working together very closely, Mr. Waxman.
Now, have you had the funds for the outreach and been able to succeed because you had the funds available or used your funds in a more efficient way?
Mr. Waxman, I would think that we have used the funds in a more efficient way, and certainly with Ohio being among the 30 or 33 states that are in a true recession at this time, that is our obligation, and our governor has made it very clear that Dr. Halpin and I and the rest of us will work more effectively.
Has your state added more money to the federal funds than, let's say, New Jersey?
Mr. Waxman, I don't know whether we've added more than New Jersey. We certainly have made immunizations a #1 part of our program. When I am asked what is the #1 priority in maternal and child health, I say immunizations. It's not in my bailiwick, but it is so fundamental to me as a pediatrician for a quarter century that I just have always made that as my #1 priority.
Well, it's obvious that the federal government sends money to the states and public health people to buy the vaccine. That's the first thing. So that if somebody comes in and can't afford it, they have the vaccine there and they'll be immunized. But we need to do more because we're talking about a measles problem with low-income, poor inner-city people, racial, ethnic minorities. Some people have come to this country from places in the world where measles was nothing that even met their radar screen of understanding. They never had measles shots when they were kids. Nobody else in the little village did either, and they don't know about it. Now, when their kids get to school age, then they understand they have to have them immunized. But with measles, we have to get them immunized beforehand. So we have to not just buy the vaccine, but reach out to them. And both of you in your state experiences have done that, not with the federal government telling you specifics, but with your looking to be flexible enough to meet the needs of the local community with outreach personnel. Is that correct, Ms. Stinson?
That's true. That's in fact the only way we're going to be successful to engage the local communities and the people in meeting this issue together.
See, Dr. Roper testified how he was a local public health official and wouldn't want to see things micromanaged from the top, but I don't see how a local health public official can hire the outreach personnel to tell them to do whatever needs to be done, given what that community problems may be, unless they have the funds to do it.
That was my point, sir.
So the funds have to be there, not the micromanagement of those funds. Is that a correct statement?
We do need additional resources for outreach, yes.
Do either of you think that we ought to have a legal requirement that would cut people off from eligibility from other programs if they don't go in and get their children immunized?
Mr. Chairman, I'm certainly opposed to that. I think in listening to Dr. Roper's testimony that certainly philosophically he is right with my answer. Dr. Bart talked about marketing. Dr. Roper talked about combining the money with personal responsibility. And Dr. Guerre, is one of your early folks, stated how important this tied-in relationship is. And I think that we're doing with the limited funds a reasonable efforts in Ohio, and I would think that many of the other states are having the same experience. And to have 40 or so people die, and you know, back when I was in training is the last time we had an epidemic like this. That we do have to do these things, and the answer is just not money. The answer is putting together organizations up and down the line, and a mutual respect. One of the
well, it
questions
seems to me somewhat strange to say we're going to penalize people who don't come in to get immunized, to take them off a WIC or AFDC. I would imagine that one of the biggest areas of problems are people who aren't even eligible for WIC or AFDC because they're illegals or they're legalized aliens. They're not going to be able to get WIC or AFDC. But in this country, we want them immunized. We want those children immunized because we don't want them to get the children to get these diseases. And not only that, if there are more people unimmunized, it means that there's a greater chance that the epidemic's going to spread. Dr. Dunstan, what's your reaction?
The important element here is to be sure that we determine whether a child has been appropriately immunized at every opportunity that we would have, whether it be an AFDC setting or a WIC setting, and then once determined, then to also link that child effectively with a source for immunization or provide the immunization there on the spot. Mm-hmm. We would stop short, however, of saying that deficiencies in immunization status would be a reason for exclusion from any of those entitlement programs.
Okay, thanks. Dr. Rowland?
Thank you very much, Mr. Chairman. Dr. Dunstan, I like your term user-friendly that you have here, and I believe that is true, that a system must be user-friendly for people to use it. So many times individuals may be intimidated by a system that is put into place and consequently won't use it because of that intimidation. And you outlined several things that you thought could be done to improve the delivery system here, and I agree with all of the things that you said. You said that the situation is not currently like that in our delivery system for immunization. In your experience, do you think that there are enough people in local communities who would get involved in helping to create a user-friendly system if they were called upon to do so? Are there people out there who would volunteer and become involved in this type of system without just saying we need more money? Because the possibility more money is certainly attractive, but I don't think just more money is going to be the answer to our problem. Would you comment on that? Well,
drawing on my experience as a local health official, I would say I'm very optimistic that many people and organizations would be very interested in being actively involved. In fact, we just had a visit from the Junior League statewide asking that they somehow get involved in a public information campaign on the need for immunizations. I think there are many organizations like that who would want to participate. But first we have to define the problem. Many people were not aware that we had a serious problem with our failure to immunize, and then the reasons for that problem, some of the deficiencies in our health delivery system. That needs to be a generalized understanding on part of many parts of our population, and then once that occurs, once that awareness occurs, I think you'll get many people who would be interested in helping to relieve some of the problems that we have.
Where does the responsibility lie for making the public aware of that problem? You say we have to get them to understand what the problem is. So where does that responsibility lie?
I think actually it lies all along the line, from the federal to the state and to the local level. But to be most effective, we have to engage our local communities.
I certainly agree with you. That is where the action really has to take place. Let me ask you, Dr. Quilty, about the increase in the incidence of rubella this past year as compared to 1988, when there were 225 cases of rubella reported, and in 1990, 1,093 cases of rubella reported, a large number of those in 15 years older people and infants. Now, the chairman has written to GAO along with some other members of the House to ask them to evaluate the impact of FDA's policy of excluding women in childbearing age from participation in certain drug trials. Would you comment on that for me?
Mr. Chairman, Dr. Rowland, the my experience goes back to in St. Louis in 1967-68 when we had the last rubella outbreak, and we had, I personally saw about 3 or 4 youngsters born with the blueberry muffin syndrome and with all of the other sequelae. So I'm very familiar with the rubella. I would think that the issues that have been addressed by the National Advisory, Vaccine Advisory Committee, they address this in one of their recommendations, that or something else I was reading over the last weekend. The bottom line is that with the very premature sexual involvement of many of our young men and women, that to have the young women involved in any kind of drug trials without having assurances that they are not pregnant would be not appropriate. I'm not sure that I did understand your question.
The question was to exclude women of childbearing age from some of the studies. FDA does that now, as I understand.
Mr. Waxman, Dr. Rowland, I would exclude them only if they are not willing to assure that they are not pregnant. Because I just in this week's New England Journal of Medicine, there was 2 articles and an editorial about the use of Valium in a pregnant woman, in which there appeared, based on the data, to be an association between the ingestion of this particular drug and spina bifida. I looked at the data. I think that this will be another step along the line in trying to determine what these causes are. But I think that does highlight so dramatically the careful way in which we must be able to take care of this particular population.
There is a significant danger of vaccinating a pregnant woman with the rubella vaccine.
Yes, there is, with the live vaccine. I would like to offer that the answer to the resurgence of rubella that we just have seen in recent months is the same answer as that to the resurgence of measles, and that is we need to assure adequate immunization coverage for preschoolers with the first dose of vaccine, particularly MMR, since they are given together, and also for those who are for the second dose of MMR. If we could assure adequate coverage with those 2 doses of vaccine, then we could abate the resurgence of rubella as well as measles.
Somewhat distressing to realize that young people over 15 years of age and even going to college had not been vaccinated against rubella. And I mentioned the outbreak in North Georgia that we had, and at the University of Georgia, you would have thought that those people would have availed themselves of those opportunities to be vaccinated. Their parents would, the children, when they were younger.
Mr. Waxman, Dr. Rowland, I'm not an expert in immunizations, but being in pediatrics, I can say that most of those children probably were immunized, and their level of herd immunity probably dropped under a crucial number, and our colleagues at CDC would have to provide that number. That appears to be what happened, and as you know from reading the papers, Ohio University in Athens, Ohio, and one of our other universities, Cleveland State, I believe, did have an outbreak of measles at the same time that your schools did last spring.
Thank you. Thank you, both of you very much. Thank you, Mr. Chairman.
Thank you, Dr. Rowland. Just one last question. Dr. Dunstan, Dr. Quilty has testified that the Ohio Health Department has arranged to purchase all Medicaid vaccines at the federal price. Since you are the witness for the State Health Officers Organization, could I ask that AASHTO survey its members and tell us how many states have made such arrangements and supply that information for the record?
Yes, sir. I'm certain we would be pleased to do that.
Thank you. Well, I want to thank both of you for your presentation. It's been very helpful to us.
Thank you.
Thanks. Our next witness is Mr. David Anstis, Vice President of Marketing for Merck Sharp & Dohme. Merck is the only manufacturer of the measles vaccine in the United States. The company has recently announced an increase of 6% in the price of this vaccine. Thank you very much, Mr. Anstis, for coming today. Your prepared statement will be in the record in full. We'd like to ask you, if you would, to limit your oral presentation to no more than 5 minutes.
Thank you, Mr. Chairman. I am David Anstis, and since 1963, when Merck introduced a safe and effective vaccine for the prevention of measles, Merck has been a part of the solution to the lingering public health problem this hearing has been called to address. In these remarks, I will suggest a renewal of the nation's immunization initiative that was so successful in the 70s. But first, I will respond to the subcommittee's request for pricing information. When the National Immunization Initiative of the federal government was launched in the 70s, Merck provided the government with a substantial discount in the price of its combined measles, mumps and rubella vaccine. This was to support immunization programs for the poor. Nearly 2 decades later, that discount remains in place. The public sector price today of a single dose of our MMR2 vaccine, which protects against 3 potentially debilitating and life-threatening infections, is $10.89, or 48% below the private sector price. Briefly, this is the history of MMR2 pricing actions during the recent period of demand increase. We did not increase the price of the product for 3 years. In 1990, we further reduced the price to the CDC by 12.5%. At the same time, we extended this discount to state and local governments. This action resulted in an incremental saving to the public sector of some $12 million last year. Last month, MSD raised its prices generally by 6%, including the price of MMR2. This was consistent with our policy of holding all price increases within the CPI. Even so, the government is still paying 85 cents per dose less than in 1988. If the price had simply kept up with inflation, it would be almost $3 more today. Based on 1990 purchases, this represents a savings of $22 million this year. As the chart on the easel shows, Mr. Chairman, the cumulative price of our vaccine to the public sector since 1972 has lagged the consumer price index. Had our aggregate price increases only kept pace with the inflation rate, the price of MMR2 would be $6.20 higher than it is today. Expressed another way, the federal government has saved $180 million in the last decade alone. Mr. Chairman, these facts clearly demonstrate that Merck's vaccine pricing history is one of responsibility. In conjunction with the report of the National Vaccine Advisory Committee issued in January, Merck has met with officials of the CDC and other groups to discuss gaps in the nation's healthcare system, with immunization a particular focus. On several fronts, work is already underway to implement national and local initiatives. In our own backyard in Philadelphia, for example, in May there will be an immunization campaign featuring an intensive outreach effort including door-to-door canvassing and multiple immunization sites. Merck will provide financial and other support. In June, the CDC will hold its National Immunization Conference. We propose the creation of a national coordinating committee to guide the work of all interested groups and suggest that it be included as an agenda priority during the conference. In closing, I would like to say that Merck takes understandable pride in having developed a vaccine that serves as the basis of solving this problem, a vaccine that has saved America more than 8,000 lives and over $10 billion since it was introduced nearly 3 decades ago. Energy, willpower, and a cooperative attitude will bring measles under control again. Merck is playing its part. Mr. Chairman, I'll be happy to answer any questions you might have.
Thank you very much, Mr. Anstis. Let me begin by recognizing that your company has a long and productive role as a participant in the efforts to immunize children, and you are the acknowledged leader in the research and development of vaccines, and you've had this commitment for a long time. But with all due respect, I don't understand your pricing of the measles vaccine. We're in the midst of an epidemic, and you're the only manufacturer of the vaccine. And all of our earlier witnesses told us that they need money for outreach to find the people who don't come in for vaccines, immunizations, yet they have to spend the money first on the price of the vaccine. So if the price of the vaccine is going up, they have less to spend to reach people. The government guidelines in place since the late 70s require every parent, one way or another, to buy your products. You have every parent in this country buying your product, either paying for it themselves or they're having the government pay for it. And the government guidelines of last year at least quadrupled your domestic sales without you having to do anything. No advertising, no marketing, nothing. Suddenly your sales have been quadrupled because we've decided that there are 2 doses of measles vaccines that should be administered, not just 1. Can you explain to us if why you're raising your price? Is it because you're raising your price of all other Merck products? And if you make a tranquilizer or an antibiotic, that's not the same as a vaccine that everybody's required to buy. Why do you have to raise the price on the vaccine just as you would raise the price on these other products?
Well, there's several questions there, Mr. Chairman. I'll try and respond to each one of them. First, let me say that we first started to see an increase in demand for measles vaccine in 1989. And at that time, we responded by not adjusting the price of the vaccine in line with our other products. Then in 1990, when we saw demand peak, in our opinion, for the vaccine, we in fact offered to the CDC a 12.5% discount on price. It's true that this year, in line with the general price increase for all of our products, that we raised the price within CPI by 6%. Nevertheless, the price today is still lower than it was 3 years ago. In terms of why would we increase our products by CPI, let me make several observations. First one is that we have a publicly stated policy to not increase our prices beyond CPI. We think that's a responsible policy, and it involves us in making certain productivity improvements. Our costs do rise, and this year we will spend $1 billion on research, and that figure will grow at some 15 to 16%. Specifically on vaccines, although we never link individual products to individual projects, Merck is primarily a researcher, developer, manufacturer, distributor of vaccines. You have to put in counterpoint to the increase in sales, which we certainly did derive from the second dose for MMR. You have to put that in counterpoint with things such as our capital project spending. For the 6-year period from 1989 to 1994, we will spend $227 million dedicated to biological manufacturing, not insignificant amount of money. Last year...
Let me just explore what you've said.
Sure.
You have to increase, you say, the prices on all your products in order to put your investments into research and the other activities. Some of the other activities, I'm sure, are marketing. You don't have to market this vaccine. Unlike your other products where you have to market them, there's a government requirement that this particular product be purchased for every child in this country. And then, not only was there a government required to be purchased, the government came back and said, in light of new information, it has to be purchased twice for each child in this country. You certainly don't have any other product for which there's that kind of a mandatory market, do you?
Well, we have, our label was adjusted last year by FDA to incorporate the second dose. We did have a requirement to explain that change to the physicians that we call on, and we did do that. I repeat that the additional sales, which we certainly derived, are nevertheless funding many other things. Just in vaccines alone, I think you'll be aware of our contributions in broad terms, but specifically just for vaccines. We are working on, one of the questions you put to Dr. Roper was the multivalent vaccine, and that is a project that's very much in the forefront at MSD. We are working on a hepatitis A vaccine.
I know you're doing good things. This research is important, and that's why we've always supported the patents that give it a monopoly to drug companies that develop some breakthrough drug so they can get the full benefit financially, because they need that to put into research and development. But here we have an unusual kind of product. Let me just ask you for a quick yes or no. Do you have any other product that you are manufactured that is required by law to be sold to the consumers?
Off the top of my head, I can't think of any.
And I've heard about volume discounts, but this sounds to me like a volume price hike. When you have large volumes of your product being increased by government order, not purchase order, but government mandate that every child be immunized twice by measles vaccine, it seems to me there ought to be a discount, not a price increase. How many doses of vaccine did Merck sell in the U.S. each year that the government required only 1 dose of vaccine per child?
Well, the figures are confidential, but the birth cohort in the U.S. Is of the order of 4 million children each year.
How many doses of vaccine are you projecting to sell this year when the government is recommending that all children get 2 doses?
I would prefer not to reveal, for competitive reasons, our total sales, but I think it's a matter of record. The purchases made by the public sector, which will be CDC, state and local, and last year they purchased of the order of 7 million doses. This year we see that figure or a slightly lower figure being purchased.
Well, CDC alone is buying almost 12 million doses, so that's just the public sector, and overall it may be as much as 18 to 20 times the other number, since we have to catch up on immunizing people who only got 1 dose.
That's,
is that inaccurate?
That's not a figure that I'm familiar with. We can check that with you.
Okay. Now, isn't the first dose and the second dose the same product?
That's correct. It's the same product.
I'm not an economist, but I've heard people discuss something called economies of scale. The per unit price of making 2 million widgets should be lower than making just 1 million widgets. Does it really cost you the same amount of money to make each dose of 3 million doses of vaccine as it does to make you have you make each dose of 6 or 10 million doses of vaccine? And are there no economies of scale in your manufacturing? And does the real cost to you per unit never go down?
Well, in fact, our costs of production last year, Mr. Chairman, rose. We were, in response to the increased demand, we were producing vaccine 24 hours a day, 7 days a week to keep up with production. It is not a simple, straightforward manufacturing process. It's done by fermentation, and it does take 6 to 9 months for product to emerge.
I understand that the price of your vaccine in Canada is substantially lower than the United States. Why?
That is correct. All international price comparisons have to be approached with some difficulty and trepidation, and they can often be misleading. It is true that the price up there is lower than the US price. However, in several European markets, the reverse situation is the case. The particular circumstances in Canada, that it was a competitive situation up there several years ago. Subsequently, that competitive product has been withdrawn from the market. Nevertheless, exchange rates alone will account for many of the differences that you do see in international comparisons.
Am I hearing you correctly? Are you saying that when you had competition in Canada, you had a lower price, but now that there's no competition, you're going to go back up in price?
No, I'm not saying that. I acknowledge that there was, in that situation, competition. In the United States, as you pointed out,
that accounted for lower price.
I'm saying that that was a factor in the lower price. In the United States, there is not competition. The vaccine is not patent protected. It is a safe and effective vaccine, and it is one that another manufacturer could choose to bring to this market.
Well, I don't understand. Canada's health system is very similar to ours, yet they get a lower price for the purchase of their vaccine. Competition may be a factor. I assume in some countries, government regulation is another factor for lower prices.
Well, There are many factors. In Europe, you have a variety of different arrangements, but in many markets there, including markets where there are competitive products to our own, the price is higher than that paid by the U.S. federal sector.
When this is the only drug available, the only vaccine available for dealing with measles, you're the only manufacturer, the government mandates that your product be sold, we're in the middle of an epidemic, it seems to me hard to accept the idea that U.S. government, U.S. citizens should be paying more for this vaccine in order to make up for the fact that you had to lower a price when you had competitors in one country, or you had to lower the price because you had government regulations in another country, that our consumers should be subsidizing the lower price for other countries buying this vaccine. I'm obviously arguing with you, but let me just, and I don't know if it's going to be productive for us to go back and forth, because you have your answer that you need to raise the money and you want to put it into research, and that's a good, worthy objective. But let me close by saying that we have a great deal of respect for your company. You've been an industry leader in a number of ways, and I'm sure you'll continue to be. You give drugs away to the third world. You do first-rate research. You work with government to restructure the payment systems. I think there's something else we ought to ask Merck to do. As you and your board and your shareholders discuss your plans, see if you can find a way to hold the line on measles vaccine prices for a little while, just long enough for us all to get this epidemic under control. The federal and state governments are all trying to control measles as we control budget deficits. We're between a rock and a hard place, and we haven't controlled your prices. Only you can, at least at this point. We really need your help, and I'd like to ask you to take back to your board our request to review this decision.
Mr. Chairman, I'll be happy to take that back, and in closing, I'd just like to point out that the price movements that you see on that chart, we believe responsible behaviour, and the discount that we provide the federal sector of 58% to the catalogue price, even absent competition, we think is a major substantial contribution in addition to our research efforts for the particular programs that are so important.
Dr. Rowland, sorry I've taken.
Thank you, Mr. Chairman. I'm pleased that Merck is still in the business of manufacturing vaccine. There was so much difficulty with that a few years back. Many of the manufacturers got out of the manufacture of vaccine because of the liability and many other reasons. So this increase in price that you have, and if it does not increase, why not? And if it does increase, how do you justify it?
Well, I think I mentioned that last year, in fact, our costs of production rose because of the particular circumstances of producing the vaccine. Obviously, our total revenues derived from the product increased because of the increased demand. And it's a matter of record that you can see that the public sector purchases, I think, were an additional 3 million doses last year, and you can see the amount of money that added to Merck's revenue stream. But in counterpoint, again, I draw attention to the various costs we have. One of the important products that we've just introduced, again a pediatric vaccine, we've heard a little bit about it this morning, is the vaccine for Haemophilus influenza. And last year we just completed an important landmark study establishing the 2-month indication in Navajo Indians, and that study, for which accounts are still being received, cost over $9 million, which simply illustrates the expense involved in research.
Are you saying that your profit margin did not increase then?
Last year, our costs of production rose. Our revenues certainly increased, our total revenues from the vaccine.
But no increase in profits?
In terms of margins, no. In terms of total money derived, yes.
Okay. All right. Well, that's a question I particularly want to ask. Thank you, Mr. Chairman.
Well, I thank you for your testimony. I would hope you would take back our appeal, and especially after the first-year startup costs are absorbed, we had hoped that we could see some price downward for this drug that is needed to control this epidemic while we're in the middle of the epidemic. Thank you very much for your testimony.
Thank you.
Our last panel of witnesses includes representatives of 2 organizations long dedicated to improving the health of America's children. As part of that mission, both groups have been very much involved in trying to help address the nation's current measles epidemic. Dr. George Pitar is Director of the Division of Pediatrics and Infectious Diseases at the Rhode Island Hospital and is appearing today on behalf of the American Academy of Pediatrics. Ms. Kay Johnson is here representing the Children's Defense Fund. She serves as Senior Health Specialist with that organization. We're pleased to have both of you here this morning for this hearing. Your prepared statements will be in the record in full. We'd like to ask, if you would, to limit your oral presentation to no more than 5 minutes. Dr. Pitar, why don't we start with you?
Thank you, Mr. Waxman. The measles epidemic indicates a much broader problem that goes far beyond the number of reported cases. Outbreaks of other diseases can be anticipated if the underlying causes of the measles epidemic are not addressed. And as previously noted, congenital rubella cases have been reported, particularly in Southern California. And by the way, I hope that you will ask me about the indications and contraindications for rubella vaccination in women of childbearing age in the question period. As previously mentioned, vaccines have been highly effective in preventing infectious diseases, and in this time of burgeoning healthcare costs, the cost effectiveness of vaccines needs to be reiterated and emphasized. For every $1 spent on immunizations, we save an estimated $10 in costs to our society. Ideally, children should receive immunizations as an integral aspect of comprehensive preventive health care programs, and these programs should be covered by all third-party payers. Immunization should be administered in a health care setting to avoid fragmentation of care, and optimally vaccines purchased with federal funds should be made available to all providers, public and private, as is the case in some states already, including my native Rhode Island and the neighboring Massachusetts. The American Academy of Pediatrics has proposed an access plan that would guarantee affordable, comprehensive health care, including immunizations, to all children, adolescents, and pregnant women. Enactment of this proposal is the Academy's ultimate goal, but in the interim, other improvements in the childhood immunization system need to be implemented immediately. The Academy supports the recommendations of the National Vaccine Advisory Committee, and I would like to take this opportunity to highlight some of these recommendations that are consistent with Academy policy. First, all third-party payers should be required to include routine childhood immunizations as part of their basic benefit package. This recommendation is consistent with the Academy's initiative for access to comprehensive care. Ideally, immunizations should not be provided as an isolated service, but as part of a package of preventive services that are covered by all third-party payers. Two, the current assumption that only 50% of the population depends on public sector clinics for immunizations needs to be reevaluated for budgetary purposes. Increasing vaccine prices are forcing more and more families to seek immunizations through publicly funded clinics, where the out-of-pocket costs are significantly less than in a pediatrician's office. In Dallas County, Texas, for example, the percentage of children referred by pediatricians to public clinics for immunizations increased 693% between 1979 and 1988. Reports from pediatricians across the country and earlier testimony this morning indicate that this shift from the private to the public sector is a nationwide and disturbing trend with implications for fragmentation and impedance of delivery of health care. Three, the Medicaid program should ensure that all Medicaid providers are adequately reimbursed for all vaccine administration and guarantee that providers receive vaccines purchased through low-cost federal contracts. Four, a computerized surveillance system should be developed to monitor age-specific immunization status of young children. This system could be used to ensure that each child needing immunizations is identified and contacted and allow retrieval of the child's immunization status when he or she interacts with the healthcare system, such as in a pediatrician's office, a public clinic, or an emergency room, for reasons other than immunizations. The federal government discontinued funding for data collection on immunization rates in 1985, and we need this data now to address and to correct the problem. Five, the vaccine status of children enrolled in federal entitlement programs such as the Supplemental Nutritional Program for Women, Infants, and Children, the WIC program, and the AFDC program should be assessed, and when needed, these children should receive their immunizations as part of their ongoing health care. Preventive care must be an integral and specified part of these programs. Where comprehensive health services are not available, immunizations could be given at WIC sites or special clinics serving AFDC children. Healthcare providers, 6, should take advantage of all opportunities to vaccinate children and reduce systematic barriers to immunization. These barriers include such practices as making immunization available only by appointment, requiring physician referral for immunization, and charging administration fees. Similarly, public health clinics should be user-friendly, and we like this term, by offering immunizations at times and locations that are convenient to parents. 7, finally, additional financial resources must be appropriated for immunizations and improvements in the immunization delivery system. In recent years, the National Vaccine Program has been instrumental in advancing and coordinating our nation's vaccine delivery system. An example is the Infant Immunization Initiative, which has resulted in renewed public health efforts by the Division of Immunizations at the CDC to develop means to immunize the preschool population. Congress should provide adequate appropriations to support the specific goals of the National Vaccine Program, which include strengthening the vaccine delivery infrastructure. The Academy commends you, Congressman Waxman, and your colleagues for leadership in passing legislation in support of immunizations. We recognize the need for additional funds and strongly support the need for funds for the Haemophilus vaccine and the second dose of measles vaccine. Stockpile of vaccines should be ensured, and emergency funds should be held in reserve for use in combating outbreaks. Most importantly, though, additional federal support to enhance vaccine delivery systems is essential. Thank you.
Thank you, Dr. Pitara. Ms. Johnson, I want to pull the mic closer.
Mr. Chairman, Dr. Rowland, on behalf of the Children's Defense Fund, I want to thank you for this opportunity to testify today and to commend you for holding this hearing to call attention to the problem of childhood immunization. In the context of our work on improving access to care, particularly for low-income children, CDF has become increasingly concerned about the nation's failure to protect infants and toddlers through timely immunization. My testimony emphasizes 3 points. 1, that immunization should be a top priority in the federal agenda. 2, that there is an urgent need to improve our nation's immunization system. And 3, that action must be taken in FY92 to strengthen the nation's immunization system and protect all of our children from preventable disease. Immunization should be a top priority on the federal agenda because vaccines are the most basic preventive health care tool. They have saved billions of dollars and have saved millions of lives. There is an urgent need to improve our nation's immunization system because we know that each year the immunization system fails to reach hundreds of thousands of children with protect them from 8 vaccine-preventable diseases. Only 50 to 80% of 2-year-olds are adequately immunized, and less than half of poor and minority preschoolers in our nation's cities are fully protected. Our failure to vaccinate children on time has led to outbreaks of preventable disease. Key barriers to immunization have been identified by the National Vaccine Advisory Committee, and I'd like to briefly summarize 3 of those barriers. First, that we know that children have inadequate access to primary and preventive care. It is very much like the problem of access to prenatal care. Low immunizations are only one indicator of many children's inadequate access to health care services. Poor and minority families are more likely to live in medically underserved areas, and as a result, they are less likely to have a regular source of health care. We have shortfalls in the health care system. We know that immunization programs across the country need additional resources, that half of programs reported to CDC that they did not have sufficient resources to do their jobs adequately in immunizing children, and that in a survey of community health centers conducted by the Children's Defense Fund, over 1/3 of centers were forced to purchase supplementary vaccine from manufacturers at private sector prices, and many centers reported the same resource barriers as local and state health departments. We finally know that provider policies and practices lead to missed opportunities to vaccinate children. Public clinic policies that limit access to immunization services, poor coordination among publicly funded programs, and failure of private providers to routinely offer immunization services are common causes of missed opportunities to vaccinate our youngest children. The actions that we must take, I'm going to make 6 recommendations. First, that we expand the federal commitment to the purchase of vaccine in the public sector. We know that each year the administration proposes to purchase the same number of doses, assuming roughly 1/4 of the total vaccine market, or about half of all of the public sector costs. This approach is particularly inadequate in the case of the second dose of MMR, or in the case of new vaccines such as Hib, or if we're going to launch an all-out national attack on hepatitis. In fact, fact, the percentage of public sector share currently provided through the federal grants varies substantially by vaccines, and these policies need to be reviewed. We also know that publicly funded health departments and community health center clinics were forced to turn away children last year or to seek vaccines on the private market. Funds for the CDC grants program should be increased in FY92 so that this no longer occurs. In addition, we support strongly funding for the vaccine stockpile. A second area of improvement is having adequate financial support for publicly funded clinics. This is a central recommendation of the National Vaccine Advisory Committee and is strongly supported by the Children's Defense Fund. At a minimum, the $20 million recommended in the President's budget for this purpose is needed urgently in FY92 to reduce the barriers created by insufficient clinic personnel, hours, and locations. We also recommend that these new funds for rebuilding public sector efforts be targeted to the areas of greatest need, and CDC consider alternative approaches to providing incentives to areas with low immunization levels. In addition, adequate funds should be available for public sector bulk purchase of vaccines for community health center patients who are among those underserved populations. The third area is coordination among public assistance programs. We need to encourage this, but no child should be denied nutrition, health, or other supports based on immunization status. We recommend that Congress monitor administration policy in this area and reject any legislative amendments to change eligibility requirements for public assistance programs targeted to low-income families. Fourth, planning must begin now for a more efficient system to track immunization status. Several other nations now have a central national registry for immunizations. The United States has the technology but has not put the plan into place to apply the tools in that area. Fifth, we need to ensure that we have safety, efficacy, and availability as primary goals in our national program, and that we lead with a vision about the future potential of vaccines. That's the mission of the National Vaccine Program, and without a coordinating agency, our immunization system is stalled in some areas. At the same time, we know the President's budget proposes to cut funds from the National Vaccine Program. This comes at a time when the program has begun to activate interagency coordination, is preparing to release the first comprehensive national vaccine plan, and has demonstrated real success in getting public and private experts to work together. We know that if we're going to ensure progress toward making safer pertussis vaccines available, advances in combating our problems through a children's vaccine initiative, and advances in areas like sexually transmitted disease, we need the National Vaccine Program fully functioning. And finally, we need to support the programs that serve families in medically underserved areas. The Community Migrant Health Centers programs and the Title V Maternal and Child Health Block Grant programs are the basic infrastructure for our public health system serving families and children. They make the nurses available in the clinics. They make sure that the doors are open and that there is some place for low-income families to go. We can't just buy the vaccine. We have to create a system in order, a public health system that will support its administration. And without adequate funding, those programs cannot make those clinics and health personnel available in rural, urban, or any other kind of communities. Thank you.
Thank you very much for your testimony. Ms. Johnson, you talked about the need for community health centers to buy vaccines at the federal price. Do you believe that legislation is needed to ensure this, or could this be done by regulation and contract?
It's not entirely clear yet. This is a policy that is under discussion. I know with some of the federal agencies are now negotiating. There are negotiations going on between BICTA and HRSA and them cooperatively with the Centers for Disease Control. There may be an opportunity to have this go on simply as a matter of regulation, but it's not yet clear.
Dr. Pittard, do you support the idea of tying eligibility for poverty programs to immunization?
Well, I think the language is critical. If linkage is used to deny benefits, then we're very much opposed to it. If it's used to improve vaccination rates, then I think it's a major step forward. In other words, I think linkage, when it's used to ensure that children both receive their entitlements and receive their vaccine, would be a major step forward. So the nature of the details of the program would be critical to the to our support of it.
Ms. Johnson, what do you think the effects on immunization and overall children's health would be if immunization were required as a condition of eligibility in poverty and feeding programs?
I'd like to talk about the two parts separately, thinking about WIC for a moment and AFDC as a separate component. We are extremely concerned that we would miss children's opportunities for nutrition supports if WIC eligibility were either withdrawn or withheld on the basis of their immunization status. As you said earlier, Mr. Chairman, we do not not now have a system that makes immunization services routinely and readily available to every family, and that has to be our top priority. And that situation makes the notions of penalties particularly onerous, particularly if we're talking about penalizing families and children. In the case of AFDC, I think we're overlooking a critical linkage that we already have there. Every child who is enrolled in the AFDC program is entitled to Medicaid coverage, as you know. The Medicaid program has an obligation under federal law to inform families about opportunities to receive a range of preventive health services through the early and periodic screening, diagnosis, and treatment program. If EPSDT and Medicaid were well functioning, every child in the AFDC program would be up to date on their immunizations. And that's where the linkage has to be made stronger, and we really need coordination. We set apart the means to finance that service, and now we need to go about linking those families through that system.
Dr. Rowland?
Thank you, Mr. Chairman. Dr. Patera, you mentioned that all third-party payers should be required to cover routine childhood immunizations as part of their basic coverage. Should we address that on the federal level, you think, or when you realize that most insurance requirements are dealt with on the state level?
Well, I think federal leadership would be very helpful. I think it would be, to me, it's incomprehensible why it's not a requirement for all health care insurance plans to provide preventive services. And immunizations is really the most successful preventive program, and I think for it to be mandated at the federal level would ensure that it indeed takes place. To allow the states to do so may take much longer.
Do you think that we should have legislation on the federal level to require that then?
Yes, I do.
Okay. I noticed that you also said that a large percentage of children were referred by pediatricians to public clinics for immunizations, and you referred to Dallas County, Texas, and that this was a disturbing trend and that it would fragment and impede delivery of health care. Explain to me how that referring children to public clinics for immunization does that.
Well, the reason for the referrals was that these were families who could not afford to pay for vaccines, but they could afford to come to the pediatrician's office for other care. So the pediatrician would refer them to the clinic so that the child could afford to pay to receive the vaccine at the same time that the child was still receiving the rest of their care from the pediatrician. And this creates, you know, a multiple sites for medical care rather than one-stop type shopping for medical care.
How would you
the study was published in Pediatrics in February and probably should be part of the record, but the reasons clearly was for the benefit of the child, so that the child could receive those vaccines.
How would you propose that be dealt with then if they're not referred to a public clinic to keep everything in one place? How would you propose to deal with that if they could not afford to pay for the vaccine?
I speak now as a person from Rhode Island who was born in Massachusetts, and in both states all vaccines are provided in both the public and private sector in a private pediatrician's office, supported by vaccine purchased by the state. And I think this is a model to ensure that vaccines are universally available for all children.
And it can be administered privately, and the pediatricians do that without making a charge for it in their offices?
Well, there may be an administration fee, but I think you have to remember that pediatricians now spend a lot of time in informing parents about both the benefits and the risks of the vaccines, and I think this becomes part of their office practice. So, and I think this should be covered within third-party payment plans. I think in earlier years we used to believe that simply a child would come into a pediatrician's office and receive the shot. We now expect far more of our physicians. We expect them, and rightfully so, to spend time with their parents, and I think to me that is part of an administration fee, and is a very important aspect of ensuring that the public is aware of the benefits of the vaccine as well as the possible risks of the vaccine that they receive.
I understand that it does take time to do that now that we probably didn't have to do in the past, but I guess my question is still, is the vaccine itself, if it's given to the pediatricians without charge, and I believe that's what you said in the state, then there's no charge made for the vaccine itself?
Well, I can't say that's right. There is no charge for the vaccine. Whether or not there is a small administration charge, I'm not sure.
And you don't know how many states may have that kind of plan?
Well, I know as of the last time that I asked this question of Dr. Ornstein and his colleagues who have surveyed this in some detail, that the 5 New England states were the only states, and I believe other states have begun to move in this direction. It certainly is more economical for a child to receive the vaccine in a private physician's office if he or she is already there rather than having to be sent elsewhere for a second service.
Yeah, I certainly agree with you that if the vaccine is given in the physician's office and no charge is made for it, that's certainly a lot better than having to send them somewhere else to get the vaccine. I would certainly support that concept if we could in some way do that.
Mr. Rowland, if I may interject one earlier comment. Earlier you asked about the rubella vaccine and dangers to the pregnant woman, and I would just like to simply correct the record is that there is no proven danger, no proven deleterious effects from rubella vaccine administered to pregnant women. It remains a theoretic concern based upon our knowledge of wild-type rubella virus. But even in cases where rubella vaccine has inadvertently been administered to pregnant women and the virus has been recovered from the fetus subsequently, there have been no adverse consequences. Hence, the emphasis is on administering the vaccine to women of childbearing age in order to prevent them from acquiring wild-type rubella disease.
That's a dead virus, isn't it?
No, it's a live
virus.
Right. So that correct.
So the rubella virus
is a live virus.
Is a live virus then. I understand Dr. Ornstein of CDC is here and could answer a question that I asked you earlier about the availability of vaccine in private physicians' offices.
Dr. Rowland, I'm not clear in terms of, you mean how many states have it? I don't know off the top of my head. The only ones I know of for sure are the 5 New England states, Washington State. I know Michigan provides DTP vaccine since it produces vaccine for people in its state. I think Jackie Noyes has a few others.
Right. The Academy can provide, for the record, the number of states that provide vaccine to the private sector.
That'd be interesting to know that, and whether or not, Mr. Chairman, we could encourage states to do that, if in fact they are not doing it already. Thank you, Mr. Chairman. Thank you very much.
Thank you both very much for your testimony.
Thank you.
It's been very helpful. I didn't have in front of me when Mr. Anstis was testifying the annual report from Merck and Company, but it indicates that in 1988 there was dividend increase of 29%, in 1987, 29%, in 1988, 56%, in 1988, 89, a 28% increase. And of course, these are dividends paid per share. So in addition to the substantial amount of money that was being put into research, the stockholders were doing pretty well in those years, and in fact it says here over the last 5 years stockholders have had a total return on investment of 427%. It might be helpful for us to get the 1990 figure as well, because that was the year when we first required the double doses of the measles vaccine be purchased, to see what kind of increase there was in sales, what kind of increase in dividends. I know that this is not just for the measles vaccine product, it's for all the products that Merck deals with, but it does occur to me that for some of the products that Merck sells, they have marketing costs. For this product, they have no marketing costs. For some of the products that Merck sells, they have to try to encourage doctors to prescribe it. For the measles vaccine, the government orders it. In other products, there's competition. For this product, there's no competition. So I wanted to get that information for the record, and again to say to Mr. Anstis, who I'm pleased has taken the position at the table, that we need your help, and when your board looks at this whole issue, maybe they can look at the sales of this product differently than the sales of other products. And while there was some withholding of increases at one time and an increase in the startup cost for one time, that maybe some of these things can be balanced off, and maybe we can get some different treatment on this issue. But we'd like to get from you, for the record, your 1990 figures.
Yes, we'll have the 90 figures. In fact, they're already available, so we can provide them to you very quickly.
But I guess the point that I would just want to bring home is that we always hear from the pharmaceutical industry about the amount of money that's going into research, and we support that. But there's a lot of money going into dividend increases as well. And maybe your stockholders can take less than a 29%, 56%, 28% return on their investments, so that we can make an investment in the children of this country not to have measles.
Well, I will certainly take your concerns back. I guess just one final comment that, of course, we are a successful company. We acknowledge that, and that's a very important facet of our ability to keep doing the good work we're doing. And in the same year that we did enjoy a healthy increase in our measles vaccine sales, that same year we had a disappointment because the vaccine that we'd hoped to introduce for chickenpox last year, in fact, could not be brought to the market. And we hope that that will be in the near future, because that's yet another contribution that Merck will be making to childhood immunization.
Do you know offhand what the dividend percentage was for 1990?
I don't have the figure at hand.
Do you think there was a sudden drop because of...
No, it was quite consistent with previous years. Not abnormally different from the 5 years that you just reviewed.
Well, I thank you very much. We'll look forward to getting that information for the record. That completes the hearing for today. We stand adjourned.
Thank you very much.
Thank you. Thank you. Roy, thanks for coming.
That concludes this hearing held to investigate the nationwide measles epidemic. For more information about these proceedings, you may write the House Energy and Commerce Subcommittee on Health and Environment at 2415 Rayburn Office Building, Washington, D.C. 20515.
C-SPAN 2 and its companion network, C-SPAN, are the cable television industry's channels for